Autism Awareness Day. We are here to understand nutrition, neuroscience, and autism spectrum disorder. On behalf of the organizing committee, I would like to take this opportunity to welcome the esteemed speakers, NEC team, Nutrition core group, and all the delegates. So we are basically looking forward to this meaningful, impactful, and insightful 1.5 hours ahead. Let me take a moment to please welcome our first speaker, Dr. Ahmed Shafi, EP. He is a developmental pediatrician from Kozhikode, Kerala, and the founder and clinical director of Dr. Shafi's Child Development and Research Center. Trained at Christian Medical College, Vellore, he works extensively in the areas of autism, ADHD, developmental delay, intellectual disability, learning difficulties, with strong focus on early intervention and family centered care. Over to you, sir. Thank you so
much. Good afternoon.
Good afternoon, sir.
You are able to see my presentation, right?
Yes, sir.
Okay. Thanks a lot for giving an opportunity, especially thank Sri Priya Madam to invite for this session. I'm really sorry I got little late. I was outside. The Wi-Fi is not available there. Sorry. So today, as we all know, today is day of autism. It's especially for us as a neurodevelopment pediatrician, for us it's very important day. And the same day that the event also came, so we planned to be this more towards autism this session. And last month we had a different plan, Down syndrome, but we changed it to autism because it's more very important and it's covers more number of people, and it's important for even for you dietitians and nutritionists and all people all over the world. So you will be familiar with terminologies and diagnosis, and I'm not going to deep of all this, and superficially I will go to diagnosis and also what is the underlying brain development or brain related issue in autism. And I will just briefly go through the updates related to this nutrition and all. And so I will start with this. And first of all, the pediatrician mostly use DSM-5 criteria for diagnosing autism. In that, we had two areas as A criteria as well as B criteria. In that A criteria, we use three things. One is social-emotional reciprocity, how socially the connecting the other people will be the one criteria, difficulty in that. Then another thing is non-verbal communication. Means non-verbal communication means using the gestures, eye contact, and initiating with gestures and all. Then relationship skills. These all get affected with autism. With that, the domain 2, where we see restricted repetitive behaviors and the insistence of same fixed interest, and also sensory issues. So sensory issues include all the 8 senses, even oral sensory issues also considered as in a criteria for diagnosing autism. So only with a criteria that all 3, social emotional reciprocity, non-verbal communication, and relationships will have affected. With 2 among the B, then only we can say autism spectrum disorder. So it is a spectrum where we can see with minimal symptoms, children having minimal symptoms with autism, and also we can see severe case of autism having a lot of difficulty in functioning and intellectual disability as a comorbidity. So coming to autism in a simple word, autism is a difficulty. Primarily, it is a difficulty of socialization. We have 5 domains as such. In that, one is cognition, learning, thinking, memory, problem solving. Then other is motor, then adaptive skills, and social skills, and language skills. Many people misdiagnose autism as language delay as autism. It's not about just language delay. It's a primary problem for autism is difficulty in socialization. So if the child having difficulty in socialization with other criteria, so some may have speech delay, or even some children will be good at speech but not good at communication, how to interact with other people. Along with this, if we having sensory processing issues and repetitive behavior and stereotypies and all, then only we can say autism. Many clients as well as many parents in my many sessions, they came and ask, my child started with talking, some kind of avoidance of some textures or avoiding of some food and all. Is it an autism? No, it's not an autism. Autism only we say when it is with social communication difficulty, if have all this difficulty. Okay. Next, sorry. So as we mentioned, it's a spectrum. In a population, if we see, it can 1 in 33 children, according to 2023 CDC, 1 in 33 children may be having autism spectrum disorder. So if you take a class, 1 or 2 children in a class may be having autism. So in autism itself, some may be functioning in a normal way with normal speech, and others may be having a severe difficulty. Based on the difficulties, there are given us 3 levels. One is level 1, requires support, social difficulty noticeable without support, and some flexibility in routines will be there. It's level 2 means requires substantial support, marked deficits in verbal and non-verbal communication. Level 3 means requires very substantial supports. They need severe deficits, minimal initiation of social interaction and all will be there. Okay. So coming to the brain development and autism. So as we all know, autism is a neurodevelopmental disorder. It should occur during the development of the child. Most of the children, autism symptoms can be identified as early as first 2 to 3 years. So some of the important signs to be noted in first year is absence of eye contact with the parent or eye contact when its child is not enjoying interaction with the human. It will be the primary thing that we notice in first year, and along with that they may be having lack of name call response. Around 6 to 9 months, child, if we say the name of the child will responding with their name code, that will be absent. Then in first 2 years, these associated sensory issues, no walking, other sensory issues may also be developed. So most of the children develop symptoms less than 3 years. If these same problems developing after 3 or 4 years, we can't straight away diagnose autism. We have to rule out other medical condition. So is an autism is a medical problem? No, definitely it is not a medical problem. It is a neurodevelopment. So it can come with medical problems too. Some conditions like seizures, epilepsy, or even with other medical and genetic neurometabolic problems, autism can come. So in most of the time, autism diagnosed in first 3 years. So we come to brain development. So what happened in this brain in first 2 to 3 years? As we all know, brain is connected with multiple neurons. So these neurons has multiple connection called synapse. See, this brain develop maximum in first 2 to 3 years. That 80% of brain occur in 3 years. By 5 to 6 years, 90% of brain growth will be finished. So in this time, maximum neurons will get connected. This connection is called as synapse, and this store us memory and skills for the child. So when these connections are getting so fast, many part of the brain get may be connected in a right way. Some are not coming in right way, or even some of the connection is not needed for the child at all. So most of the theories tell that this in autism, there will be altered way of connections. Some necessary connections not well formed, or unnecessarily many connections came in the brain. So what happens in first 2 year, when the child reaches 1 to 2 year, the brain start recognize some of the connections are not required. Then some connections should be optimized. For that, brain have a special process called synaptic pruning happen. In that synaptic pruning, brain recognize some of the part is not needed, that will be cutted, and other part will continue. So in that, children with autism, because of this altered connection, some of the essential connection between the socialization part of the brain, that is especially frontal lobe and with the temporal lobe, are not well formed. That long range connections and some of the short range connections are excessively formed, especially sensory processing issue, repetitive and the fixed interest and all. These local range connections are overly formed or not well removed with the synaptic pruning, and some essential connections are not formed well. So this is the one of the most established theory behind the brain and the autism. So is there any obvious change that can be diagnosed using MRI or some investigation in autism? Obviously, no. If some of the part is completely blank or nothing like that. So these all connections are micro level in the brain. Some of the connections are not well formed. This all are in theoretically only we can say. Many times we can't diagnose autism using any type of medical investigation. Okay. So some of the connections are well not formed, some other connections are not well formed. So in these years, as we all know, brain has a maximum potential to grow. If we identify the autism in first 2 to 3 years, we have an opportunity to endeavor in the child. This we call as early intervention. What is early intervention? If we identify the problems and we diagnose the autism early, then definitely we can make changes. We can't tell like we can cure the autism completely, but we can make lot and lot of changes. Even I saw some of the children come with simple autistic symptoms or autistic traits in 1.5 or 2 years. Within 2 to 3 months of intervention, lot of changes can be seen. It's all happened because of the brain's potential to change or grow a maximum in first 5 years at least we can take. But golden opportunity always we tell us 3 years. But at least for 5 to 6 years, we have an opportunity for early intervention. So ultimately, autism is about the altered connection of the brain that can result in altered social communication and behavior of the child with some kind of restricted interest or sensory processing issues. So the brain's altered connections can be corrected, not completely, at a certain extent, in this golden opportunity for 5 to 6. So it's a neurodevelopment disorder. And then coming to other aspect, as you all looking to nutrition or other anything related to autism as such. According to the all studies, even update cell, nutrition or a particular nutrient or a particular vitamin don't have any direct correlation with autism as such. So if we can't say this B12 deficiency, B6 deficiency, or if we have some omega-3 deficiency and what will cause autism. Definitely the answer is no. And even we are trying any biological molecule or any medication, we can cure autism as such. So there is no medication or no supplements or no nutrients can make autism or cure autism as such. But definitely child need medications and some kind of supplementation, because a lot of children with autism may be having comorbid condition. For example, even if in a normal population also we see iron deficiency, but in autism, because of a nutritional issues and sensory issues, many of the children will be having some kind of vitamin or mineral deficiency. Iron deficiency we see in a lot of children, and also vitamin D, calcium deficiency we see many times. Then many children come with the B6 or sorry, especially B12 deficiency and all. So as like any normal child, we uh, look at the children with autism, and we have to correct the nutritional deficiency. Another important issue with the children with autism having risk of having nutritional deficiencies about sensory issues. Many children may be having some kind of oral sensory issues or some kind of fixed interest. I will be eating only curd rice. I will be eating only that fruit. I will be eating only that thing. Like that may be seen in autistic child. Then many children may be having other medical conditions to also increases the risk of nutritional deficiency. And definitely, nutrition and diet have a very good role in autism. Many times we refer the children of autism to many dietitians to look at their nutrition part. So, main challenge comes, we can't correct all sensory issues as such. So, according to the child interest in textures and tolerance, we ask dietitians to make a specific diet plan. So they maybe need a crispy textured, and they will be not interested in some kind of sabji or dahi. Then we ask dietitian to modify their diet and make it a balanced diet. So coming to the medication part, other than that, supplements, many times we may be giving medication for comorbid condition of seizures. So we may refer to pediatric neurologists. Also, we may be giving medication as it's like omega-3. We many times we may giving it's all as just a supplement, not it's a part of a treatment as such. Maybe because of these all issues they lack a proper diet. So as supplements, I used to give omega-3, and sometimes I used to give multivitamin supplements along with other medications. So what is the role of medication as such? Medication only we give when the child having behavior success, irritability, restlessness. For behavioral part, we give many time medicine. That too, we don't give medicine in early age. Later phase only, we give medicine. So coming to the treatment and management of autism. What we do for autism, as I mentioned, there are altered connection. In order to form the connection early, we start early intervention. In the early intervention, we first look at the deficits of the child. As I mentioned earlier, we have 5 domains in development. Along with the social domain, child may affect other domains also: language domain, motor domain, cognition domain, self-care domain. So first we need a detailed development assessment of child with a multidisciplinary team of a development pediatrician or a pediatrician, with a child psychologist for looking at the social and cognitive aspect of the child, with an occupational therapist looking at the motor skills and sensory processing issues of a child, and a speech language pathologist looking at the language and speech. After a proper development assessment, we multidisciplinary team sit together and plan a therapy plan for a child. So along with the parent, we have to train the child and the family as such to do this therapy in a daily basis. So we always encourage parent-mediated therapy because that is the most evidence-based therapy as such. Along with that, we have to look on the other aspect of the child. Many of the children with autism will be having, apart from social difficulty, learning difficulty may be having. Some of the children will be having ADHD as such. ADHD, as we all know, it's attention deficit and hyperactivity disorder that can be a comorbid condition with the autism. So these are the usual way we manage the autism as such. So I think 20 minutes is over for this session. And
Thank you so much, sir.
Thank you, ma'am.
Sir, will you be able to take up questions now or can you wait?
You so now I can take no issues.
Sir, I have a question. So we say that the brain development happens rapidly in the second trimester and then the third trimester as well. So is any in utero environment or maternal risk factor is responsible for autism later on?
That's a very interesting question. So, brain development is a continuous process that most of the studies tell that first 1,000 days, that means 365 days in utero, and first 1 year and second year. Combines we say as first 1,000 days of child is very important for brain development, we consider. So, in utero, there are some risk factors like maternal smoking, and anemia as such, but there is no much evidence to say as such. They may be resulting in preterm delivery and some other complication like risk of cerebral palsy and all. But as such for autism, we can't tell.
So basically, as such, if I ask you, like, what is the cause of autism? Like, can autism be prevented? Is there some answer for that?
As I mentioned earlier, it's a neurodevelopmental condition. It's not a pure medical condition as such. So preventing autism many times we have many things to do as such. So it's not happen in a birth as such, but we if we see as autism, there is a three kind of autism we see looking at the trajectory from early infancy, from 1 or 2 months itself. It's evident that baby is not looking at all, and if baby may be having any underlying genetic condition, then early phase we see that signs of autism comes. But other group, majority of group, autism 1 to 2 years we see. Means
Okay.
many of the brain, as I mentioned earlier, pruning process and all happen in this time, and some of the connections are forming in that social, higher social, and all will be more towards 1 to 2 years. So there is an entity called virtual autism, but it's not a true entity or a scientific thing. But in the COVID time, many doctors or many people come up with this terminology. So poor social environment, especially a child not having enough people to talk or interact, especially social skills development. For social skill development, there is no environment as such favorable for a child, and excessive screen time. This all can act as a contributory factor for autism. But definitely, I see many children, twins coming, one having autism and other don't have the autism symptom at all. But we can completely blame just because of screen or some kind of unengagement result in autism. But it's a contributory. So in such cases, definitely within 2 to 3 months of proper social engagement and removing complete screen, definitely improve the child. So according to the Indian Academy of Pediatrics and American Academy of Pediatrics, first 2 years recommendation of screen is 0. And 2 to 5 years also, limited screen less than 1 hour can be given. That to content are very important. So in a simple way, can we prevent autism? No. Definitely,
Okay.
we can decrease the problems in autism. Definitely, with the proper social engagement. Child should have a good caretaker as such. Means styles as in all part of brain, especially social part of brain, child forming a proper secured attachment in first year. So
Okay.
a primary caretaker should be there. Even if the mother is going for work, somebody, trusted person should be there with the child all time. Then only a proper attachment of the child develop. So
True.
if the child attachment is insecure or not develop the attachment properly, that itself may result in social skill deficits, and in some studies even future psychiatric problems may be result because of an insecure attachment. So in first year, most important thing we should take care is avoiding the all screen. Some person It's okay. Not needed to be a mother should take leave for entire 2 to 3 years. At least 3 to 6 months, if mother possible, should be there with the child and one trusted person. Trusted person in the sense, if you have a good caretaker, it's okay. Many time, grandparent will be the right person to support the child. Then maximum, the parent should be there with the child. Both father and mother have equal role in child development. So if we give a social relationship and a proper attachment and avoiding screen as such, we can prevent many of the social emotional problems that develop in child in future.
Thank you, sir. Just one more thing to add. So basically, I work in a hospital. They have a unit for child development center. CDC is what we call, wherein we see a lot of kids like this. Most of the parents, they say that the child initially had a good conversation, was absolutely okay, and then later on, because of certain things like parents getting busy, etc., especially in COVID, both the parents were doctors, etc., then they started to notice that the child was not behaving properly. So does this happen, like the brain is having a good connection initially, and then because of certain change and environment change,
Yeah,
autism develops?
definitely that only I told in a pruning process. So that happening after 1 year. That some of the connection brain itself remove. So brain recognize these connection are not essential for the
Okay,
child.
okay,
So
okay.
if the child is not getting properly engaged, that social communication part of the brain is get disconnected or removed or not properly developed. So according to of all of these theories, especially we can't tell completely is a regression, not developing that area as such or some kind of disconnection happens.
Okay, okay.
Participant,
Thanks a
there are
lot,
a
sir.
few more questions in the chat box.
Okay, ma'am.
Participant, can you
So
read it out?
yeah, 1 minute, ma'am.
Yes, sir.
I can read, I can. So one question, first question came as, ma'am, so nowadays there is a trend for more nuclear families, lack of communication with child and more screen time. Does these things also impact neurodevelopment? Definitely, we already answered that question. And other thing, when age of the diagnosis, in order to diagnose it as such, we need at least to wait till 1.5 to 2 years, but we can see early symptoms from infancy itself. Ideally, 2 to 3 months, baby should develop a social connection with a human. That means social smile will be starting around 2 to 3 months. Then baby can identify the family members by 6 to 8 months. Stranger anxiety will be the name called responsibility. So some of the symptoms of this autism can start as early as 1 year. But in order to diagnose, in order to label autism, we need at least to wait for 2 years. Then definitely many of the in community level, even pediatricians and all people can use. Even you, for you also, it's applicable. If you find any child come to your clinic not having a social engagement as such needed for a age, you can for a MChat. MChat is MCHAT. It's a simple tool that we can screen in community level the child developing the risk of autism or not. So that can be applicable from 16 month of the child. If you feel if MChat is getting positive or if you feel strongly suspicious of some signs of autism, definitely you have to refer pediatrician first. To rule out all organic problem, directly don't refer to any therapy as such. So the problem is that if the underlying problem comes with some other organic or medical cause that does not get treated at all. So first you have to rule out child have any vision problem. So it can be due to vision problem also, not just because of lack of social eye contact. So some kind of visual impairment is some kind of a cerebral visual impairment or hearing problem too. Or it can be due to some metabolic problem like the hypothyroidism can also result in some of the, maybe starting with signs of autism too. Okay.
Sir, I
Then
have a
other,
question.
tell me.
So whenever people come to us, their main problem is more than anything, whether it is a dietitian or doctor, like what will my child become? So what are the education options or career options available in India? Or what is
Definitely,
there
ma'am.
any?
Definitely, I work more towards early intervention. I see children from birth to 14 years many, even if he says severe autism with a lot of comorbid issues and all, if we give a proper intervention, definitely the child will be living like any other child or a human, we say. So many of the children will be going to normal school, in a regular school, going for job, work, everything happen. But if the child didn't got a good opportunity of intervention, or child is so having symptoms are so severe, or having some genetic underlying problem, definitely child may need support. It depends on the child cognition level. If the child is severe intellectual disability, not coping with a regular school, definitely you can go for a special school. And according to child's strength and weakness, we decide what career option child can go. But if you're going to as such for a higher education and higher education over in schooling, over even in a job option, definitely children with autism come under 21 disabilities. So they will be getting concessions, and they will be having concessions in schooling. They will be having getting special scholarship. They for a job also they have 1% reservation. So right now I'm in NIPMED Chennai. Actually, I came here to have a visit in National Institute. You may be knowing that it's an Institute for Multiple Disabilities. I'm taking these sessions from NIPMED itself. So I'm just going through the all career options and all, and what all aids and all. It's not for just autism, all disabilities.
Thank you. Thank you so much, sir. That is also very interesting and needed information, because whenever parents come, their concern is all about the future also.
Autism is not just like it's not a, we can't say it's a disease condition. It's a
Yes.
differently able. They have a different abilities as such. So according to child, definitely they can go for job. Even some child or adolescent perform much better than regular, but they may be having difficulty in socialization, because with the use of new adaptive means, devices and communication devices, definitely they can overcome all these things. Uh, Straight away, if we ask if a child want to put in a special school or a regular school with a normal child, definitely autism child should be with a normal child or regular base. Then only they will learn socialization. We can't teach socialization or social skill in isolated therapy room. Definitely they should go for, from play school, they should go in a normal regular mode, Anganwadi, play school, then LKG, UKG, like that they should go. Other question came as any genetic test to prevent mother conceive. Definitely no, because the cause of autism many time we don't know actually. Many multifactorial we say. So any if the family having any kind of genetic disorders that to result in autism, then you can go for a genetic issue. Or if you have the children with autism and it's already the doctor diagnosed with some underlying medical or neurometabolic problem, then you can go for a genetic test before conception itself. And how to start work with child go hyperactivity. Hyperactivity is a different topic as such. It's not, it can be part of autism or even a normal child, and it can be part of ADHD as such. So it need a lot of interventions because we had to look at that. Why this child having restless or hyperactivity, even simple iron deficiency for restlessness. Many time doctors miss that. Even simple iron deficiency result in irritability and hyperactivity in children. Some of these studies, even with the normal hemoglobin, we may not find it. Early, we have to go for a serum ferritin, and only we can find early iron deficiency. Even vitamin D deficiency cause hyperactivity.
Sir, I have a question. Like, the child, my child is not diagnosis like proper autism. They said कि epilepsy है and there are things, but उसका walking issue I can see. Or the question you answered is asked by me only, so I'm a little bit concerned because he's just sitting and playing the toys with the toys, but all of the sudden I don't know what happened and he start throwing the objects, the toy, or if he whatever he get in his hand, he'll just throw it out. And I think maybe he like the sound.
It may be. Drawing or any kind of behavior, we need a detailed behavior analysis. Any kind of behavior may be to get attention of the child or attention of someone else, or it can be task avoidance, or it can be a mode of communication, or it can be a sensory issues. So it's need a detailed behavior analysis as such, and only we can tell why the child behaving that way.
Thank you so
Yeah.
much, sir. Thank you.
So I think other lectures are waiting. Shripa ma'am's lecture is already waiting. And I think no more questions asked to answer, no? Okay.
Yes, sir.
I hope I will be joining with you in some other time too. I'm really interested in nutrition, and I'm very thankful to Shripa ma'am as well as the organization to give such an opportunity on a nice Autism Awareness Day itself. And thank you all.
Thank you so much for joining us with your busy schedule, sir. I'll definitely send you the recordings of the sessions, sir.
Sure, ma'am. Sure. Thank you, ma'am.
Thank you, sir.
So let me welcome Dr. Sripriya Shaji. Dr. Sripriya Saji is a counseling psychologist, dietitian, and entrepreneur advancing food mind science. With expertise spanning nutrition, psychology, and neuroscience, she integrates clinical practice with research in areas like eating disorders, neurodevelopmental and neurodegenerative conditions, and maternal mental health. She is the founder of Srisha Counseling and Srisha Academy and holds globally recognized certifications including SCOPE and Monash University credentials. An accomplished speaker, she has authored 20 research publications and presented 23 papers, serving as founder trustee of the Community Nutrition Forum, chief program officer at IAPEN, and co-editor of Mind Matters International Mental Health magazine. We welcome you, Dr. Sripriya Shaji.
Hi, Fariza. Thank you. Thank you for the brief introduction. As our time is little less, I'll be like moving on to the session quickly. Just give me 2 minutes. I'm trying to move the slides from the Zoom link. Can you see the Zoom link moving? Yes?
Yes.
Thank you. So today we are in the very important day. Autism is one of the very important area the children have to be addressed with the nutrition. So we are going to talk about gut, brain, and the genes, how it is interconnected. So the very important question is, what is behavior is a biology in disguise? So children with ASD is facing is almost 4.18 fold of increased risk from the functional gastrointestinal symptoms compared to other neurotypical peers, and significant to ignore the clinical practice. Okay, so the very important shift for the dietitians, I think 20-25 years before when I was joining, the shift was very less. Like, what are we going to do? What change are we going to bring in? But today the scenario is totally changed, and diet is no longer just an alternative medicine. It is a modifier of neuroinflammation. So directly influencing the brain function through the microbiota gut-brain axis. So today our learning objective is on the analyzing the mechanism of microbiota gut-brain axis and its dysregulation, and how to intervene this, and precision role of understanding the role of precision nutrition like nutrigenetics and MR in individualized risk assessment of ASD. And also I brought in some small clinical framework for us to understand. So most of you must be knowing that Mendelian randomization is an epidemiological method that uses the genetic variation as an instrument to determine if a specific modifiable exposure, for example, the risk factor like a high cholesterol causes outcome. By using this genetic modifiers or genetic markers which are assigned randomly at the conception, MR minimizes the confounding factors and reverse the causation. So that is the about MR minimization. So understanding autism is very, very important. Like the clinical definition says that persistent social communication deficit and repetitive behavior patterns and prevalence, like approximately 1 in 36 children in US and roughly around 1.8 to 2 million children in India are estimated to have autism spectrum disorders. So the immune dysfunction goes like aberrant cytokine profiles to chronic low-grade inflammation. Like metabolic dysregulation like mitochondrial dysfunction and redox imbalance is very common. And the GI pathology is very, very important, like constipation, diarrhea, and intestinal permeability defects are also like the multi-system factors, comorbidities. Is the screen moving? Like I'm not able to see the screen.
Yes, ma'am, it's moving. Now we are at neurobiology simplified slide.
Okay. So understanding the neurobiological substrate of ASD is a foundational to appreciating why this nutrition-based intervention can exert the measurable clinical effects. So in the very altered cellular bioenergetics is a common and reproducible metabolic phenotype across the ASD subgroups and affecting the neural energy supply and synaptic functions. So another thing is metabolic biomarkers like elevated plasma lactate and specific lactate containing ratios correlate significantly with the lower developmental quotients, that is DQ, and the language deficits like actionable. These are the actionable red flags. And another important thing is emotional intelligent imbalance and glutate GABA dysregulation is a central of core behavioral symptoms including hyperactivity, anxiety, and social withdrawal, fear kind of things in ASD. So nutrition and neurology interface, like as I said before, diet is not a peripheral consideration. It is a primary environmental lever acting on the microbiota gut pathology, gut axis. So diet, microbiome, metabolites, and neuroinflammation are the key layers on the things. So the neurotransmitter synthesizes, like specific gut bacteria synthesizes GABA, serotonin, and dopamine, and neurotransmitters directly implicated in ASD phenotypes. So what are the cytokine modulations we can see? Targeted diet reduces the pro-inflammatory cytokines such as IFN Y, which cross the blood-brain barrier and contribute to the neuroinflammation. And the primary lever diet is the single most modifiable determinant of microbiota composition, giving clinicians the direct and actionable therapeutic targets. So pathophysiology of like the basic pathophysiology of the gut microbiota and gut-brain axis. So it is a bidirectional communication, as we all know. The microbiota gut-brain operates through the three integrated channels, the neural pathways, the vagus nerve in the superhighway of gut-brain signaling, the probiotic behavioral effects, or abolished upon the vagotomy and confirming its centrality. So immune pathway like cytokines such as IL-6, IFNY serve as the molecular messenger between gut immune cells and the CNS. The short-chain fatty acids, particularly butyrate, regulate the microbial and blood-brain integrity. So the vagus nerve, when the gut is inflamed, the vagus nerve carries those inflammatory signals directly to the brain by altering the mood and focus. So the key clinical insight is 95% of serotonin is produced in the gut by enterochromaffinin cells under direct influence. So what are the microbiome alterations in ASD? Like mainly the dysbiosis characterized by the reduced microbial diversity and altered bacteroidetes to firmicutes ratio and deficits lower levels of bifidobacterium and prevotella and pathogenic enrichments, especially higher counts of clostridium and Desulfovria hydrogen sulfide producers. A reduction in this bifidobacterium is particularly concerning as it is associated with the lower levels of folate and B12, which are critical for neurodevelopment. So very important thing we have to understand is the neuroinflammation and oxidative stress. So in which the chronic low-grade inflammation is not localized to gut, these cytokines like elevated pro-inflammatory markers like IL-6, IL-1 beta, and IFN-Y are consistently found in blood and CSF of children with ASD, sustaining chronic neuroinflammation and disrupted synaptic plasticity, and also like leading to the neuroinflammation through leaky gut mechanism, like increased intestinal permeability, allowing the endotoxins like LPS and undigested food peptides to enter the systemic circulation and triggering the immune compromises. So what are the pathophysiology? There were like metabolic phenotypes. There were studies like especially the CAM study identified around 153 autism associated metabolic biomarkers. It has like heterogeneity of ASD and necessity of metabolic subtyping before intervention. So in this, we can identify the specific metabolites subtypes of autism, which allows us to move away from one size fits all approach to precision metabolic therapy. So the mitochondrial autism subgroups with low free carnitine and branch chain amino acids benefits from targeted supplementations, and high plasma lactate is the red flag for more severe social and communication deficits. So this is a very important challenge in nutrition, because whatever you plan, whatever you do, cook, or many times your mother, the client's mother will come and say, ma'am, we have done so many things, but he is very selective. So the prevalence of selective eating is very high in autistic children, like around 69% of children have this food selectivity, and this is often driven by the hypersensitivity to the texture, smell, and color. These are the main drivers, like appearance of the food, texture of the food, smell of the food, and rigidity, like 69% selective. Impact is monotonous diet. They will be very selective about the same type of diets. Like for example, only fried items. I have seen a kid who always eats like dosa 3 times a day. She can eat a dosa. Like it is mainly they are associated with high in sugar and processed food, exacerbating dysbiosis. So feeding problems are 5 times more likely in ISD. This isn't just a picky eating, it is a kind of sensory based biological challenge. So this is the very important area, why they go picking also, like why they are not hungry, why they are not eating, which is right, because the high prevalence of the chronic constipation, diarrhea, and abdominal pain or hallmark comorbidities, like affecting the majority of the children with ASD. And the GA correlations, like GA symptoms severity, often matches the ASD behavioral severity, like kind of irritability, lethargy. Many will come like and say in our local language, Marian, that is too lazy to do anything. He just sit, watch, and nothing. They just keep sitting. There is no interest to anything, or they're not running and playing. This kind of complaints is also associated with the GI symptom severity. So addressing the GI health can elevate the non-verbal behavioral, as doctor already mentioned. This addressing the GI disturbances is one of the very important thing which can help in the non-verbal behavioral outcomes. We must also screen for GI using standardized tools like the Roman 4 criteria or Bristol stool form scale. This is also one easy to screen non-invasive screening tool. So very important, we have to, like from the day one, micronutrient deficiency is the important area. As dietitians, we have to see the nutritional gap happening directly with the neurodevelopmental consequences. Like especially the fat soluble deficits will be like significantly lower serum levels of vitamin A, D, and K will be there. And this also, like children with the ASD are statistically shorter than neurotypical peers due to their long-term protein and micronutrient deficiency. There is growth impairment is happening, and vitamin D levels are inversely related to ASD severity scores. Like folate is crucial for DNA methylation, a process often impaired in these children. This is another important thing which we are talking so much in the normal nutrition landscape, probiotics, which can restore the microbial landscape. So here in ASD cases, restoration of microbial diversity. Even recently in one of our groups, there was a talk of whether it is a good functional microbiota or the diversity is needed. Yes, we definitely need good functional microbiota, but for the development, we also need the diversity, and micro strains like formations are more effective than the single strains. That is very important. And L planetarum PS 128 showed a very large effect size, like in reducing hyperactivity and impulsivity in younger children, according to the researchers, and use as a adjunct treatment for GI symptoms and emotional dysregulation. Don't use it for every other times, like mainly use for this particular GI symptoms and emotional dysregulations. And meta-analysis shows the borderline significant benefits for core symptoms, but shows like a strong benefits for associated symptoms like anxiety and focus. Strains with qualified presumptions of safety must be prioritized. So, like, what are the mechanism when it comes to the prebiotics and fiber? The non-digestible fibers like galacto-oligosaccharides stimulate the beneficial bacteria and increase the short-chain fatty acids, and it may reduce the antisocial behavior and improve the social skills. And gorgum has demonstrated, like, shown to decrease the behavioral irritability and improve the constipation in children. Like it is very effective for managing constipation and potentially dampening the neuroinflammation via butyrate production. Prebiotics are acting as a food for good bacteria. They are often better tolerated than live probiotics in children with high food sensitivity. So many children, like with the food sensitivity, they may not like accept even for the curd. I have a kid who never touches curd or any kind of milk products. He doesn't have any lactose issues, but his liking to the milk and milk products is very, very low. But for his conditions, mostly we use this gorgum, and that really works. And for a long time, we were talking on the gluten-free, casein-free diet. This used to be one of the very important opioid excess theory, eliminating gluten, casein, peptides that cross the brain-blood barrier and mimic the analgesic effects. So this retrospective study with 78 participants, like dramatically reduced the milk and wheat specific IgG levels. The mixed results are kind of core behavioral symptoms in meta-analysis, but most beneficial for the subgroup with identified allergies and sensitivities. If there is no allergies or sensitivities, we need not stick on to this particular thing. So this is very controversial clinical data which shows the reduction in food-specific immune responses. It should be implemented like based on the IgG sensitive screening rather than as a universal role. Like no more, many of us are using it as a universal formula. I think at least 1 out of 10 of my patients are in need of the gluten-free or casein-free diet. So anti-inflammatory is a very important thing. Like it is reducing the pro-inflammatory, like Th1 cytokines, by limiting the additives, sugars, and increasing the omega-3 and polyphenols. So there was an important study. Please go back and refer to this study, Neuro Gut Plus Trial Evidence, which was a 12 weeks randomized clinical trial, which has a significant reduction in the IAPEN, right, and stabilizing effect on the global immune profiles. So exert the broader and more consistent immunoregulatory effects than probiotics alone. So the NeuroGut Plus protocol is a very comprehensive approach. Low gluten, casein, FODMAPs also is combined with the high omega-3s and fermentable fibers. So another important thing we always talk about is the omega-3 fatty acids as a brain fuel. It is enhances the neurotropic factors like BDNF and act as a precursor to anti-inflammatory resolvents associated with the emotional regulation and social interaction. Deficiencies are linked to poor synaptic plasticity in ASD models. Like supplementation is essential given to the low intake of fish in most of the ASD cohorts. Like many people, like they call themselves non-vegetarian, but they may not be using on the daily basis, or many children may not like the smell of the fish and so many things. So the supplementation becomes essential only in those cases. Like EPA and DHA are very critical, and high dose of omega-3s are often used as an adjunct to help stabilize the excitatory brain. So when it comes to the micronutrient supplementation, like when it comes to vitamin D, there are RCTs showing significant like reductions in stereotype repetitive behaviors and improved social effect. So vitamin D is one of the primary immunomodulation and neurosteroid synthesizer, and vitamin A is crucial for oxytocin signaling and neurogenesis. Deficiency correlates with the severe CASCO and requires for the metallization. Clinical trials shows gains in the communicable and language like folate and B12 plays the main scores. We are just treating the deficiency. We are using these nutrients as the cofactors for the neurotransmitter synthesizers. Next is the very important ketogenic diet, which we often use for the epilepsy care, is also used very well in the autism care too, like which induces the ketosis to induce mitochondrial bioenergetic shift and increases the GABA synthesis. So meta-analysis reported a significant like reduction in the core ASD symptoms in small cohorts. Like it is the best for ASD children with comorbid epilepsy or high neuroinflammatory markers. If in the minimal cases, I don't suggest, but in higher cases, I always suggest the ketogenic diet, which shows the best results. And the KD requires strict kind of medical supervision due to the risk of hyperlipidemia and the potential growth impairment. So what I do in my clinical setting is like we have a dedicated dietitian who will be doing the everyday follow-up, and we have a Excel sheet formulated like a Google form, and we'll send it to the parent, and the parent has to fill every minute detail in that. So we'll be continuously following on the daily basis for over a period. So it helps us to overcome this growth impairment and hyperlipidemia issues. This is the one of the important kind of power kind of sustained intervention. So FMT, fecal microbiota transplantation. So restoration of microbial diversity via fecal microbiota transplantation has been done, and improvement in social interaction and communications were maintained for up to 2 years, like post-treatment in the longitudinal follow-ups. So it demonstrates the most consistent and long-lasting benefits for both behavior and J health. So FMT is kind of moving from experiment to clinical consideration. It addresses the root causes by completely remodeling the gut ecosystem. So this is a summary about intervention evidence and strengths. So you can see the highest quality evidence currently supports the multi-strain probiotics for behavior and fecal microbiota transplantation for the sustained severity reductions. So this is the table for understanding like multi-strain probiotics or having the hyperactivity focus, and it can be used for all ASD and J symptoms. And the strongest is FMT, fecal microbiota transplantation, and one of the emerging is anti-inflammatory diets, and vitamin D and omega-3 and all has shown a moderate kind of stereotypical social communication or emotional regulations. And whereas like GFC F is also like having the GA related behaviors mixed subgroup dependent. So this is another important thing we dietitians must be knowing on the area of nutrigenetics, because precision nutrition is becoming the very important area to work on. And in autistic specifications, we are moving into the child's genes dictated how they process the very nutrients we are giving them. So the genotype diet interactions like genetic polymorphism necessitate the personalized folate and B12 dosings, and MAOA variants, that is monoamine oxidase A polymorphism, may influence the behavioral response to trace the mineral supplementation, particularly in zinc and copper balance. Like personalized nutrition models should incorporate genetic screening alongside the metabolic profiling. So this is about the MR, Mendelian Randomization Casual Dietary Insights I was earlier mentioning. It allows us to bypass the picky eating bias of observational studies. This is providing the genetic evidence that specific food genuinely influence ASD, like risk to immune pathways. Some of like the genetically determined higher intake of whole wheat pasta or gluten and cheese bread is linked to the elevated ASD links. However, genetically determined higher intake of bananas is casually associated with the reduced ASD ring. This is one of the important findings. Like banana effect, they say it enrich in tryptophan and phenols that improves the serotonin precursors. So the future is not just the diet books for autism. More than that, it is a kind of personalized lab-based protocol for each child when they are in the moderate to severe levels. Multi-omic integration of genomics, metabolomics, and neuroimaging helps in identifying the mitochondrial autism versus immune dysregulated autisms, and transitioning from kind of general autism diets to individualized restoration protocols. So individualized microbiome restoration protocols are helping us to tailor to each child's genetic and immunological fingerprints. So this is the assessment framework, like a stepwise approach. We can see the baseline assess the usual anthropometrics and GI symptoms using the Bristol stool or a Roman 4 criteria, and use 3-day log, like very important 3-day logs like diet quality index, and test plasma lactate and free carnitine and food specific IgG antibodies. We must start with the objective data, like if height is low, investigate the protein and vitamin D status. Likewise, we have to make it objective according to the every child's need. And when you are into the practical diet planning, adherence is the very biggest challenge than a normal population, because children will not be like okay with the initial foods or plans we are giving. So after a point, the mothers or the grandmothers will get very anxious and they will come back and say, doctor, he is not eating anything, or he is continuously, like even recently I had a client who's having on 3:1 keto. This child could not tolerate the protein. He was he was also overfed. But what happened is intolerance and vomiting was there. So they get very anxious because the child is losing weight or everything the child refuses. The parents get anxious and they cannot like stick to what we say. So adherence becomes a very, very challenging thing. That is where we need patience and structure the protocols like NeuroGut Plus delivered in the food package. Please read this NeuroGut Plus study. I can give you the link in the references. And start with the low allergen whole foods, like avoid pro-inflammatory processed sugars, jaggeries and honey. Mostly I don't allow any of these things. I'll say that sometimes they will say whether it will be nice, it will be tasty. I'll say it is yes. You just taste it, see, and then you can give it to the kid. And all those things we have to convince. It will take like literally 1.5 hours session, but choose the multi-strain blends like containing planetrum and bifidobacterium. Work with the therapist to introduce the new structures also. And if we don't measure, we don't know if it is working. So always use the standardized scales to track the impact on the diet on behavior. Have the assessment monitoring timeline, like week 0 first assessment like baseline scales and autopharometric, then next week 4 with the yearly GA response check, week 12 with the full reassessment with the ABS and social responsive scale SRS2, and aberrant behavior checklist or CORS, that is childhood autism rating scale, and GSRS. All these things can be used. And week 24 we can see the sustained outcomes, but in between also we can have every week like recorded trackers so that we can make them more adherent. And whenever there is a deviation, we can hold on it and change according to the child's need. So reassess every 12 weeks minimum to distinguish the true treatment effect from natural symptom variability to ASD. So how to like adaptation of the cultural Indian context? Most commonly Indian children with ASD or demonstrated distinct micronutrient deficiency like compared to Western cohorts, especially on potassium, copper, and folate. So like high SEBI score, children's eating behavior inventory confirms the significant feeding problem in the Indian ASD populations. So what are the very critical important research limitations we have? There is a very less clinical heterogeneity and extreme phenotyping variability, and small restricted samples are there. For many pivotal studies like NeuroGut Plus or Metabolomics or CAMP has a very small or age restricted cohorts, and many studies are also male dominated, like 4:1 prevalence ratio. It is on the boys, not on the girls. So these are the important limitations and measurement variability. So GFSCF is on the debate, and probiotic strain specificity, like not all probiotic strains function as psychobiotics. So efficacy in high strain specific dose dependent and host dependent commercial RCTs or creating translations. So the future of this autism spectrum disorders nutrition science is on the next generation probiotics, metabolic stacking, and microbiome targeted VNS. So the take home message is like targeted dietary interventions and psychobiotics can stabilize immune profiles. It can reduce neuroinflammation and modulate neurotransmitter, making nutrition at a first line biological modifier. And precision is very important and must require metabolic and genetic screening to identify the mitochondrial or immune dysregulated subtypes. So please restore over the restriction, the gut hemostasis to support the optimal neurodevelopment and microbiome diversity and behavioral well-being. So my key message for today's session is nutrition in autism is not about restriction, it is all about restoration. And here is the references which I can share in our group also. And this is one of the very important thing I have like come across. It takes a village to raise a child, but it takes a child with autism to the raise the consciousness of the village. So let us all raise our conscious level to support their nutrition requirement. Thank you for the patient listening. The questions will be answered at the end of the session. We have our SLP also to have deliver us a good session.
Thank you, Dr. Sripriya Saji. I think it was quite extensive wherein you tried touching the various different aspects. And yes, once you share the links, I think we can learn ahead.
I'm sorry I
Yeah,
took a little extra time.
yeah, I think it was a bit extensive because you had to cover all the stuff. May I now welcome the other speaker? You're going to take the questions later, right?
Yes, ma'am.
All right. So let us now welcome Jasmine Lydia, who is an assistant professor in the Department of Speech Language Pathology at Sri Ramachandra Institute of Higher Education and Research, with 16 years of professional experience, including over 11 years in academia. She completed her undergraduate and postgraduate education at the University of Mysore and began her career as a research officer at AIISH, Mysore, before working as a speech therapist in Singapore with children with autism and intellectual disabilities. She has substantial experience in teaching, mentoring students, and guiding dissertations. Her clinical and research interests encompass feeding and swallowing disorders, head and neck cancer, voice disorders, autism spectrum disorders, and cognitive communication disorders. She is currently pursuing her PhD with the focus on prophylactic swallowing exercises in head and neck cancer. She also serves as a reviewer for Springer and Taylor and Francis and has authored over 25 peer reviewed publications and book chapters. Her work is grounded in a commitment based patient centered care and enhancing functional outcomes and quality of life through collaborative clinical practice and research. So, with all this, we now welcome Dr. Jasmine Lydia. Thank you so much.
Yeah, thanks for the introduction. Can you listen and see the slides too?
Yes, we can.
Is it in the slideshow mode?
Yes.
Right. Okay. Right. Thanks for the introduction. And I think after a long day and you're going to listen to the last talk, so I'll try to keep as simple as possible. So thanks for the introduction. As you said, I currently am working as a speech language pathologist and an assistant professor in the Department of Speech Language Pathology at Sri Ramachandra Hospital here in Chennai. So just to start, before we could start off, I wanted to just show up and understanding on what a speech language pathologist usually think about feeding and swallowing, because the topic that we are going to discuss, I think I missed to say that, is multi-dimensional feeding difficulties in autism and implications for SLP collaboration. So I understand most of you are nutritionists, and so how do we actually collaborate to get this multidimensional aspect go on? So with this idea to start off is where I wanted to bring out the factor that feeding and swallowing definitely is an aspect that is required for the growth, and it is a primary need where we talk about in terms of oral phase, pharyngeal phase, and esophageal phase. So you saw that you're seeing in this video on how the food from the oral cavity passes through the pharyngeal cavity to the pharyngeal phase and then to the esophageal phase. Now, what is important for us to note here in terms of the first phase or the oral phase, we also see here that the food, that bolus is formed where the food passes through the oral cavity until the back of the tongue. We call this phase as oral phase. Now, what is so important here, when we talk about something called feeding, we are actually referring to this oral preparatory and oral transit phase, where the food is taken in and it is prepared. So it's oral preparatory phase, and then it is transit. When there's a transition to the back of the oral cavity, we call that as oral transit phase. We after the food goes to the back of the oral cavity or the oropharynx, then we have pharyngeal phase, which is actually where food then passes to the pharyngeal region, and then the swallowing areas are triggered, and then it is more to do with an involuntary process. You can't control it. It's an involuntary process, and food just passes down and through that to the upper esophagus sphincter, where the next stage starts, which is actually your esophageal phase. Now, why are we talking about all of this? This is for our understanding to note that Feeding and swallowing are two different terms. I wanted to just bring that to your notice that feeding is to do with more of how food is being prepared in terms of how the motor aspect, sensory aspect, behavioral aspects, and how it is got into, um, prepared to produce or have ready for swallow. And the swallowing phase is more of physiological phase where you have food passing from the oral cavity and then from the pharyngeal to esophageal phase where it is more involuntary and this goes on. So we call that as physiological phase. With this basis, okay, so with this understanding, to be on a common ground, I just wanted to start off today's understanding on what we call as pediatric feeding disorders. If there is a failure to eat adequately or gain adequate weight with the not directly relating to the medical condition, if there's an onset that is before the age of 6 and then and that is not related to the lack of food or mental health disorders, and then we call that as pediatric feeding disorders. In case of children, so when there is an impairment in the oral intake, this is not age appropriate. So you know that I had this slide with lack of time. I just didn't play this, but for your understanding that from 0 to 6 until the last 2 to 5 years, we move from reflexive feeding to mature feeding. Now, with this understanding, we know that the child goes from liquids to purees to different consistencies. And so it is important that the feeding is always taken into consideration based on the age. So skills has to be age matched. And also it is important for us to associate the medical nutrition feedings, uh, nutritional feeding and psychosocial dysfunction, which may relate to what we call as pediatric feeding disorder. So today we're going to talk about that periodic feeding disorder in case of children with autism, especially focusing on this multidimensional feeding aspect. And also I wanted to highlight the critical role of speech language pathologies in this multidisciplinary team. And so by the end of the session, I guess you will be able to carry out 4 takeovers. One, definitely understand the multidimensional nature of the feeding disorders in children with autism, which we did talk about from the first and second presentations too. Second, to analyze the interaction of these factors and how does that recognize us to collaborate, and then what is the SLP's role and how can professional collaborate, other professionals can collaborate with us. So with this understanding, I think we will go to the first idea because I thought of doing Mentimeter, lack of time. So let's just do this. Can each of you just put one word on your understanding on feeding in children with autism, just in case, because we have been doing hearing, listening. So maybe I want to just listen to, can I have someone just put something on the chat box? Maybe a word, anything of that sort.
Yes. Can you see?
Yeah, okay, yes. Vicky, yes. Maybe all of you can try something, anything that you know. Yeah. Yes. Okay, so with that, few responses that I've got. likes, dislikes, smell, feel, eat, yes. Sensitive to textures, swallowing difficulties, portion, challenging, yes. So this gives us an idea on, just a second. Can you see the slide moving?
We are at the slide. Let's hear from you. Yeah, now it has moved.
Okay, thanks. So, so with this understanding, of course, I know that all of us, many of us, a few of us could be working with children, and then you would be also handling feeding difficulties in this cohort. So, we definitely, as I heard from others too, is typical feeding behaviors, some distant feeding difficulties that the children may exhibit. Just the statistics, 5 times more, the feeding difficulties in the children who are diagnosed with ASDs are 5 times more when compared to the age match typically functioning pairs. So that's actually quite a lot. So we also heard from earlier presenters that, and this feeding difficulties, it's a long term, has a long term consequences, and it is life across, spreads across the lifespan. There are percentages of about 46 to about 90% of the children who might prevalence of the who might show up feeding difficulties, and this we already spoke on the previous presentation that it may lead to mealtime stress. Of course, you all know that growth compromises, nutritional deficiencies, obesity risk, GI problems, and of course, poor mealtime interactions, and so on. So when extensive literature search was done to identify this particular multidimensional factor, there was list of definite factors that came into picture where the researchers that show about food selectivity, about food neophobias, anxiety, refusals, oromotor deficits. We heard few in the chat box too, and parent-child interactions and all. All of this definitely shows a factor that feeding difficulties are complex, it is pervasive in nature and heterogeneous in nature. So this makes us to understand that feeding difficulties are multidimensional in nature. It is not just about medical conditions. So definitely there is medical and nutritional factors like constipation. We heard also that there could be growth concerns, nutritional concerns, dental issues, and vomiting reflexes. All those comes under the nutritional factors. We also know feeding difficulties is not just eating, where they have behavioral factors too contributing to. So there could be tantrums during the mealtime, throwing of the food, refusing certain foods, and which is behavioral in nature. It's not to do with the oromotor difficulties or sensory. It's purely behavioral in nature because they are inflexible to the food preferences. Then you have oromotor factors definitely contributing, where we are primarily working at that. So child, how do we know there could be an oromotor factors? There could be child could gag or choke. You could see that there's a minimum movement of the tongue. You could see that the child is not chewing adequately, or you might find that child is not actually letting you in, and then food is when kept in swallowed without even biting, or just the munching is done and not a proper chewing is done. Or the child might cough, showing there could be some kind of swallowing difficulty, what we call as dysphagia. And there can be, if not motor, it can be sensory. So we all know that. So that could be hyper and hypersensitivity to texture, taste, smell, and we heard that in the previous presentation also. And all of that also includes two other factors: environmental factors and parent-child relationship factors. And these also contribute to feeding difficulties. For example, the dynamics of relationship between the child and the parent does play an important role in the mealtime communication fullness or mealtime pleasure positive feedback, which definitely is lacking in case of children who have feeding difficulties. Also, environmental factors which may include, like they need TV to eat food, needing distractions, just like playing with some toys. It's also a distraction during the mealtime. Difficulty in sitting to eat, difficulty in wanting a particular routine or particular environment, one person providing the food and not anybody else, unable to maintain the mealtime routines or change the routine, etc. So all of these could be a contributing multidimensional factor. And we also heard that the reasons, there's no particular clear-cut reasons of why they might have all of these difficulties, but there could be like what we heard in the previous presentation, gut micro contributing to the factor or familial concerns, sensory preferences like their hypo or under or over sensitivity, or theory of mind could be one, like for example difficulty in understanding what is the routine, what is the expectation, what food to eat, whether to eat, when to say it is full. Genetic factors, of course, can also be a factor, or stereotypic preference. The brain itself prefers to have certain factors. So either of this, any of these. So definitely is a multidimensional clinical challenge. You all will definitely agree with that. Multifactorial and multiple systems are involved, and these systems are interrelated. And now, what is to be known? Single cause explanation cannot be given for this feeding difficulties in children. It has to be a multidimensional model that has to go on. One of the models and approach that I believe and also accept is this MOPS model, which is actually medical, nutrition, oro, motor, behavioral, sensory, environmental approach. You know, that's what it stands for as MOPS. So what I just was speaking about different factors from the different components of these models. And so what is most interesting in this factor, in this approach, is that there's a relation, connection between all of these factors. Medical, sensory, behavioral, oromotor are all linked together, connected together, contributing to the problem. So it's not just that one particular factor contributing, but it's just combination that is and also the factor that called environment. So medical, sensory, oromotor, and behavior related to the family or the child is then further being modified or modulated by the environment that is present. Environment could include parent-child, or environment could include culture. Okay, how the food preferences or culture of the particular child. So if you take up as a fragmented care, if you are doing a discipline-based intervention, you may miss up the interactions. So lack of interaction may lead to treating parts of the problem and not the whole problem. So definitely that leads us to what we say as sensory, motor, behavioral, medical, nutrition, all has to be taken into consideration. And we need to ensure safe swallowing, okay, because you don't want the food to enter into the airway. You want safe swallow. You need adequate nutrition. You also need positive mealtime behaviors. So if there is a mismatch between the feeding and the nutrition deficits, of course, that also. Sorry.
Yes, ma'am, I have muted.
Okay. Then we also have to understand that when we actually bring up an intervention plan, there has to be holistic and family centered. Now, for all of these to happen, there needs collaboration. That's your second objective or second takeaway. That first to understand multidimensional nature, and then the need for us to collaborate with each other on us. How do we do this assessment and management of feeding difficulties in children with autism? So the model, Smile et al. In 2017 and later they modified in 2022, had postulated this interaction model, which is very interesting, and I believe in, and we follow that in our clinical practice here in my settings wherever I worked. So when I talk about feeding, when I provide the therapy, provide intervention, I take into consideration all of these factors. So there will be medical. We have a KCDU like what we have child center, development and pediatrician. Likewise, we have here as KCDU integrated center, where all of these professionals work together. So feeding definitely is an input from all of the professionals working together. So no child presents with one particular domain difficulty. So we will definitely have oromotor or behavioral or environmental, combination of sensory and behavior, could be nutritional, could be medical in nature, or what I said is environment. So for example, like could be cultural, parent-child interaction, any of these domains or a combination of the domains that could result in difficulty what a child might face. Now, that gets us to understand that interdisciplinary team working together in assessment and management, helping the child and the family-centered treatment plan is necessary. This already, I think we spoke about what are the different roles we all know. As a speech language pathologist, we work with oromotor functions and swallowing and swallowing related. Of course, speech communication is our primary goal. In terms of today's topic, we work with feeding, swallowing, and oromotor functions. As a team, here what we work, we do screening and assessment and domain mapping. So what we do screening as a different professional, and then we map on what we are working on, and then we jointly make a goal setting. So once we do a goal setting, each of us will work on goals. So that's a parallel intervention because it's a hospital and then there's lack of time. So the parallel setting. When I was working in other places, we did have a joint intervention sessions too. So either it could be parallel or joint intervention sessions, and then following up with as a team, sitting with the family and monitoring the progress. So this is an integrated feeding pathway that we actually do. And this is how we move parallel care to integrated care, discipline based care to child centered integrated care. So, what I am trying to actually get this to understand is that as an audience, how can you actually relate to us in terms of collaborating practices with a speech language pathologist? So, which means when will you refer to us and when do you know that, those are aspects to be taken into consideration? So, once we take up this, understand the context, understand the risk factors and the patterns, and then we do an informal assessment. We do clinical observations, which is actually real-time functional feeding performance. We give them food and we ask them to eat, and then we also ask the caregivers, families, and teachers sometimes in the early schools to provide us information and video recordings to understand what type of settings, what type of behavior the child shows during the mealtime, how is the posture, how is the seating, how is the caregiver and child interaction. We also see for if there's gagging, avoidance, seeking behaviors. So these are behaviors which we check, and so you will also know that those can be checked, and then you know whom to refer to. And if in case the child is accepting the food or refusing the food, or child is showing rigidity in the food selectivity or picky eating, what we said, sometimes child can also go, we also try to understand if there is preference to particular texture or taste or brand, or how that is, how was the onset and how did it progress, what is the current concern. Those are aspects which we actually try to understand. Now, once we understand that, we go on with our oromotor examination during the feed time. So we before and after the feed. So structural examinations here in the videos, you could see that we do check how is that lips, tongue, jaw, palate, symmetry, integrity, and movement. Okay, basically structure and movement. We check for the tone, we check for the speed, range of the motion, if there's hypotonia or hypertonia, and how is the lip closure. If you could see the here in the video, the lip closure, lip seal. We were trying to find if we can move the tongue across and retract and protrude and lateralize the tongue. We were able to see that whether there was jaw opening and if there was stability in the jaw opening. So once we check for these aspects, we also actually sometimes use these kind of cards for assessment. So which is actually like, for example, try to use these kind of pictures. Just a second. You can just you use these pictures because it's hard for children to actually imitate what you say. So showing these pictures actually help them actually get that movement across, like for example tiger ka movement, or the frog sticking out the tongue, etc. Or sometimes that's how we actually show the card, and we also do the movement to make the child do. Then doing the oromotor aspect, we also check for their feeding skills. So here you can see in the video how is the child chewing. So we are trying to find the sucking, biting, chewing kind of aspects. So we see for how's the lip closure, are they able to form the bolus, is the suck, swallow, breath, or feeding adequate. How is is a child munching? So if you see in this video, you would see that the child is actually just munching and swallowing. It's not chewing, and there's no rotatory chewing there seen. Sometimes the child can keep the food in the mouth and pocketing of the food, and then they keep it for some time, and until you feel like that's not going in, and then mother says I need to give water to get the food in. So we check for that, and we also check for sensory motor integration. So if not sensory, if not motor, how are these two integrating to get the things done? So response to different textures. So here in the video you see child prefers to eat one type of food, doesn't like to eat the other type of food. So the moment he sees the food is like, I want to eat the other food only. So preference to that particular texture or temperature or taste. And so here also you could see the child, just cannot tolerate that food, and also oral aversion, or unable to even tolerate that particular food. Uh, so we also check if they can eat all the type of in all type of spoons for cup, and how is that spillage, and how is there a fatigue during the eating. Sometimes child after 2 3 bowls, doesn't want to continue further because of the fatigue. Those are aspects that we actually work and see. And once we get an idea on that, we go on with the formal assessment. There are tools that are available. So it's for just for you to know that SLPs use tools. So I mean, these are some things which you also, I guess, use Bambi, and we have Indian version of pediatric eating assessment tool. FOI is pediatric adaptation. That's oral intake scale. And the last one actually is a test that I have developed for children with autism. That's Indian questionnaire for feeding assessment in children with autism, because there are a lot of questionnaires that were available on various aspects. Multi-dimensional is what I wanted to emphasize. So the tool which we developed on two phases. First, we actually got around 60 70 parents of children with ASD, profile their behaviors, and then we got the second phase of the study where we developed this particular tool, and then we content validated that, and then validated among the children with ASD. So it's very easy yes or no marking, where the parents have to just say yes or no, and the observations could be done. And once, for example, like you have different domains, so you have questions mapped to that, and then you have different items. So, for example, the first behavioral food selectivity had almost 5 items, and then likewise different behavioral, sensory, GI, quality of life, motor, communication are various domains that we assess, and then we then has different items. So you get domain-wise percentages to understand which domain is more affected than the other. That's related to what the tool that we developed here. Then there's also freely available tools. Anybody can just go to the website and then download and can start using these tools. These tools are also being used just to understand the feeding nature of the children. Now, once we know in terms of assessment, we know what is the profile of the child. When we try to do is expand the food repertoire of the child, reduce the anxiety, improve the flexibility, improve the oral intake, help them to develop the skills required for oral feeding, self-feeding, and also understand and recognize the internal cues that, I'm full and I want food, or I'm full, kind of interception on the fullness and communication. So all of these are something that we work in terms of activities such as one involving just the food, two activities that is not related to food. So starting with pre-feeding activities are something that we do. So for example, like this is like what we all do, play-based exposure. Like as a parent, like we always help the child give the food, play with the food, and then without even the knowledge of the child could sometimes put in that and smell that food and all of that. So play-based exposure of the various textures, colors, tastes. You can see in the picture of how beautiful the food is being kept for the child to play. Touch and guess games also works for our children. Making funny faces, doing faces with them, some kind of DIY kind of work would also help. So this will enhance the familiarity and acceptance of the food. Basically, it's done for that purpose. And then we also work with postural support. Now you know that when a child is in a feeding posture, is important to maintain the posture right from the birth until the child can independently eat. So 90 90 90, so 90 here, 90 here, and 90 here. That's 90 90 90 posture, which we actually as an SLP recommend. That actually helps in the pelvic support. Pelvic support helps in the mandibular support. Mandibular support helps in the tongue and the jaw support. So mandibular, jaw support, tongue support, and that further helps in chewing and swallowing of the food. Then if not that, we also do for children some kind of muscle massages, or increasing the alertness, readiness, responsiveness for feeding. So we give different type of textures, and in order for child to start all of that, you want the system to desensitize. You want the system to be alert and responsive. So indirect oral stimulations are something that we also do. Oral sensory behavioral activities are the next aspect that we work on. So what we do here is to tolerate for child to tolerate various consistent hyper or hypo depending on, and increase overall awareness, food acceptance. So there are various techniques that I have noted, I have put here. So those are techniques that are available. So what I preferably do is identify what are safe foods, identify what is my goal food, and then what are fearful foods, and slowly try to categorize that, bring the safe food and then a goal food, link that together is one of the important goal and activities that we do. So that can be done in two ways that I usually prefer to. 6 steps food exposure hierarchy, tolerating the food, getting the food in the room first place, then on the table, and then on the plate, and then try the child, make the child interact with the food, and then make the child smell the food, taste the food, touch the food, and then eat the food. Those which we usually know. And 5-step food chaining, that is slowly from, you see in the picture how from the child who's eating French fries to the child who can eat mashed potatoes. So these are different in consistency, but the linking of that consistency until you reach that particular goal consistency. Now that's what we do, is slowly to introduce foods to reach to the goal food. Then our motor exercises, which we definitely do to improve the muscle strength, sensory awareness, and coordination. So how do we do that? Is basically introducing different exercises, like you have exercise for the tongue, trunk, neck, lips, jaws, and um, you know, also including adaptive utensils. So if you could see here, I just have skipped this point, but I wanted to note that this is not, researches have been done showing that oromotor is not the sole responsible technique that shows an improvement. Like, it is fantasized that use this tool, do exercises that will show improvement. No. So if you are trying to use oromotor exercises functionally, that is, you are trying to do an exercise and relate that to the function, such as speech or feeding, that's when it shows improvement. Because the skill doesn't only improve the feeding, it also improves imitation, joint attention, expansion, and help practice functional speech. Now, so what do we do here is focus on these oral structures and improve the motor functions. So you could see in the pictures and how the lips and smile and lip hold, smiling and puckering, holding, puffing, and rounding. If you could do, you can. And tongue exercises, like you have out, in, left, right, up, down, and sweep are the different exercises that we do. We also have other exercises with tongue blades, like you can use a spoon or ice cream stick or however, and then you introduce to resist, provide the resistance, and you make them do the exercises. Those are isometric exercises that we actually do. So just to understand, these are oromotor exercises that helps in actually improving the strength, tone, speed, accuracy, and coordination of the oral structures. For others, for all those to understand, these are different tools available. You can just see these are speech gears online available. You also have talk tools. These you see on the left-hand side is a tool called Talk Tools. You also have different, if not these two already commercially available, you can just use any of these that I'm showing. These are all for oral motor functions, improving the oral functions. So you can use chewy tubes. Nowadays, we also have teethers in baby hugs and first place and all. So you can use those teethers also, but therapeutically we use this chewers, and then of course the cards which I showed earlier for assessment can also be used for management. You can make the child do. There are oromotor cards available, super duper cards. Those are publishers who provide cards, and then you have board games, like exercises where you put the dice and then it goes to different mouth posture, and when it goes to the open mouth, then the child has to do open mouth. We also have app, free. These are free apps which you can just download. iOS has this app which has different exercises, and the child, you can show it to the parent to do or child to do. At the last, I said, if not only exercises, we also do adaptive utensils. These are different adaptive utensils which we can use just to show some variety and then make the child use those. And the last thing that we also do is self-feeding skills. If not only oromotor exercise, sensory and all, we want the child to eat by themselves. So that gives a healthy eating behavior. So these strategies not only enhance nutrition intake, it also improves social interaction during the mealtime. It creates an enjoyable experience for the family. Now, if in case all of these are for those children who can actually take in food through oral feeds. Now, if the child is not able to take in food through oral feeds, then we have tube feeding, which is actually not by the mouth but providing through the tube. I think you all are definitely familiar with this. So we also recommend to find if safety is a concern. Child is not safe enough to have food, then we recommend non-oral feeds. So the key takeaway, just wanted to highlight that when eating is not just eating, collaboration is not just helpful, but it is necessary. I also wanted to end saying that current evidence supports not just a reductionist model, but it supports a multidimensional interdisciplinary framework. So it's important that we integrate sensory, motor, nutrition, and environment domains together when we are trying to work with feeding disorders in children with autism. So these are the references, and thanks for your patient listening. Yeah.
Thank you so much, Jasmine ma'am. We have taken a long time and really sorry for exceeding your time also. And once again, I wish to thank each and every one of you joining us today. And I especially sincerely thank Dr. Shafi and Dr. Jasmine Lydia ma'am for joining us and giving the wonderful session for dietitians. It's an honor you be with us on this wonderful event. Thank you so much. And I also thank the NEC members, Dr. Lekha, Dr. Anshu, and our complete NeuroNutrition team and our mentor, Dr. Smilu Mohanlal. Thank you everyone for joining us. And really sorry for taking your time. The recordings will be sent to your email. Have a good day.
Thank you.
Thank you, ma'am.
Oh.